to talk to you about hormones through the lifespan. We all know that hormones play a significant role in how we look and feel, but let's look specifically at how those play a role and how they change over the lifespan. We're going to start with the intricate process that begins in the brain. The brain sends messengers through the hypothalamus to the pituitary and then to the organs called our ovaries or testes in men, and these produce estrogen, progesterone, and testosterone in women. So these hormone messengers then go out into over 300 receptors in our body and tell all of our organs, skin, tissues, joints, tendons, skin, hair, and nails what to do and how to perform. In women, we have three significant players in our hormones, those being estrogen, progesterone, and testosterone. Estrogen is what I think of as the captain of the team. She's the one that is going to go out into all the different receptors of the body, like I said, over 300, and make a significant impact on how we think, how strong our bones are, how our skin looks, how we feel in terms of our mood. And so there are over many receptors and many different skin and tissues that will be impacted by estrogen. Progesterone is known as the happy hormone. It will help us to ovulate regularly. It will also help us to be able to, come on in. It will also help us to know when our menstrual cycle is coming, and so it will help to regulate our periods over our lifetime. We often see this hormone decreasing over time first. When we go into perimenopause, we are losing progesterone. And then lastly, testosterone in women plays a significant role as well. Many people often think of this as like a male hormone, but really it helps women in terms of their libido, in the way that they have energy. It also helps with muscle tone, and it can actually help increase our muscle mass. It decreases visceral fat and protect us from insulin resistance over time. So this is a great diagram of kind of what our hormones do over the lifespan in a woman. This is specifically looking at estrogen levels. And you can see at birth, it's fairly low. It starts to fluctuate during puberty, and then it levels off through our childbearing years. And then we see that fluctuation again occur during perimenopause, which is why we often feel like we're on a roller coaster when these hormones are going up and down. And then in menopause, it of course goes back down to those birth levels. And so we feel that loss of estrogen in terms of our acute symptoms and our also long-term health. And I put this diagram on here because it really just shows us how our hormones work in symphony with one another throughout our lifespan. This is just showing you how intricate this system is in terms of not only our ovary, our pituitary, our body temperature, how our ovaries function, and also how our uterus will perform, like our menstrual cycles. And all of this works in great harmony usually until we hit about age 45 and we say something is not quite right. And that happens when we see a decrease in progesterone levels. We might start to have irregular periods. We might notice more anxiety. We'll often see difficulty with sleep. We'll have like a 2 a.m., 3 a.m. awakening a lot of times. And then we'll notice that mid-abdominal weight gain, PMS can become more intense, and this is due to those declining progesterone levels and usually testosterone as well. There was a study that they looked at over 1,400 women, and they looked at Google and they found that over 5 million times it was Googled or searched, "I'm just not feeling like myself." And they correlated this with perimenopause. And so some researchers wanted to see, what does that really mean when someone's just not feeling like themselves? So they categorized this in 5 areas. That would be anxiety, fatigue, brain fog, mood changes, and sexual symptoms. And they were doing this to really help providers be able to understand their patient when they come in and say, something's just not right, I want my hormones checked, I don't think things are like they used to be. It helps us to have the right questions to ask our patients. It also gives our patients some ways to articulate their feelings. And so I thought this was very interesting because it was the first time that they took this phrase, and now that's actually terminology that we can use in order to be able to identify symptoms and know how to intervene with treatment. So in perimenopause, what are the hormones doing? We saw that graph over the lifespan. This is exactly what in perimenopause, you see that progesterone and estrogen doing. Progesterone's in the green, so you'll see that start to fall. And so a lot of times we'll come in with treatment of progesterone nightly or cyclically, depending on how the periods are doing for the patient. And then we wait until usually much closer to menopause or true menopause before we intervene with estrogen. And then after a woman has gone for 12 months with no period, we use the term menopause then. You're in menopause for 1 day. You're perimenopause up until the point you've reached 12 months with no period, and then after that you're postmenopausal. So you're really in the menopausal transition over time, but really theoretically 1 day. And so after 1 year with no bleeding or spotting, around the age of 51, then we'll call that postmenopausal, and we'll see a decline in all the hormones. So you'll see more hot flashes, difficulty with sleep continues, brain fog, weight gain, vaginal dryness, loss of libido, and muscle mass. And this, again, is where we are with menopause. Both of those hormones have come down significantly. And so as the hormones interact, we see more symptoms, present. And so a lot of times I will have women come in because of weight gain, brain fog, sleep issues, hot flashes. And so we get to talk about how we can relieve those acute symptoms and then how we can also intervene to promote health for the lifespan. So if we go back to think about what these hormones do, if we lose all these hormones, then we are losing some of that muscle definition, just like I was discussing. Estrogen, we lose our cardiac protection, our bone protection. When they look at females and males, most of the time males outperform females in terms of hypertension, high blood pressure, until they reach menopause. And then we see at menopause, women outperform men, unfortunately, and we see those rates of hypertension higher in women than men because they've lost that protective benefit of estrogen. So what are the cardiac benefits of estradiol? Well, there was a study that looked at over 600 women. They looked at women who had just been in menopause less than 6 years and those that had been in menopause over 10 years. And they intervened with oral estradiol. And when they did, they measured the carotid arteries. And so they were measuring to see if we intervene early, will we get better heart outcomes? Will we see cardiac outcomes improve? And so what they found that there was a better window of opportunity within 3 to 5 years of menopause, no longer than 10, where we get some heart benefits if we intervene with oral estradiol and progesterone if needed. And then there's been, even this year, new research that's looked at defining the musculoskeletal symptoms of menopause to include osteopenia and porosis. We've known for a long time that estradiol is preventative. In fact, estrogen has an FDA indication for the prevention of osteoporosis. But we haven't thought about some of the other things like increased inflammation, the increase of fat mass, the decrease of lean muscle mass, what they refer to as sarcopenia. And this is often due to the decrease in the proliferation of something called satellite cells. These cells help us to build muscle. It also looked at arthritis, and so a lot of times women will come in with more hip pain, shoulder pain, frozen shoulder, and they termed this and defined some new nomenclature for menopause called the musculoskeletal syndrome of menopause. And so now there are even more specialties looking at, how does the menopausal woman present and what can we do on the front end to prevent some of these musculoskeletal symptoms. And then lastly, even again this year, we have found benefits for the brain. There is a neuroscientist, Dr. Lisa Mosconi, and her team, and they looked at women's brains, premenopause and postmenopause. And they actually did PET scans of their brains, and not once did it fail. They always were able to predict this woman's premenopausal or this woman's postmenopausal. And what they found was that, she was able to develop for the first time a tracer that traced estrogen activity in the brain. And so they looked at the receptors, and those receptors became very active and dense. And they remained that way for up to 10 years after menopause. And then after 10 years, they kind of died back down. And so again, we're seeing this window of opportunity being very important in a woman's life. When they have stopped having periods, we've got a time period to really intervene for some long-term protection of brain health, bone health, and heart health. So in summary, the hormones affect every part of our body. They will change, and this is normal. But however, normal is not always optimal, and that is our slogan, and that's why it's not always optimal. It is normal to age, but how we age is somewhat in our control. And we have some decisions to make that can help not to only add years to our life, but life to our years.